features of the device that we use for these procedures called the iClearScope, which is a wireless endoscope which enables us to visualize the earwax in the ear whilst safely removing it under direct supervision. So if you're suffering from a blocked ear and you're in the UK, please do visit our website, which is www.clearwax.co.uk. You can enter your postcode or your city and town and find your local specialist. Currently we've got around 60 specialists on our website, but that's going to be hopefully expanding exponentially over the next few months. Anyway, let's go back to the procedure. So I had this client who attended with bilateral fully occluding earwax. This is the patient's right ear. So the wax is slightly glutinous around the periphery, around the edge, more centrally in the core, it's a bit firmer. So what I'm doing here, I'm just trying to loosen the wax from all around the ear canal wall. If you can loosen the wax around the ear canal wall, there's loads of skin adhesions there. It facilitates the easier removal of the wax. So some wax at the base, some matted hairs. So wax has been there for a while, slightly dark, it's oxidized, it's turned black. Similar to an avocado or an apple. Once you slice into it, if you leave it exposed to the oxygen, to the elements, it does oxidize. So there's no real other instrument I can use. If you use an ear hook for this, it will just dissect through the wax. The wax is a bit, as I said, it's a bit soft around the edge. You'll just be dissecting it. Similarly with a Jobson horn, you'll just be squashing it to the canal wall. So the secret here is we're trying to get this out in one go. And I don't know if you can see in the background, this wax extends all the way to the eardrum, so it is lodged very deep in the ear. Around a centimetre or even half a centimetre away from the eardrum, we do get a natural, everyone has it, it's a natural narrowing of the ear canal called the isthmus. And then the ear canal expands wider again. And this wax is lodged in that isthmus, and we've just managed to retrieve that medially, so from deep in the ear. And the secret is just to get this suction grip and little wriggles, just to loosen it and bringing it forwards. If you go in a bit too forcefully with the suction probe, what you'll actually do, you won't get a suction grip. The Zollner probe, it will be almost like a Q-tip. You'll be pushing this wax further in, so you do have to be very delicate. You need to have that, and that's when you're doing the procedure, you can feel it, the pressure. So it's almost kissing the surface of the wax. You don't want to go into the wax. By going in, as I said, you run the risk of forcing the wax further in, and also the suction probe can get blocked. So it's just little motions. You can see we're bringing this forward. You can see the keratin, the dead skin that's coating this plug of wax. So we're near the entrance now. You can see all the cilia, the hairs. The difficulty now is just to navigate this wax out of the ear canal. It's almost like giving birth. You'll see in a moment, I bring this wax through the entrance, and the entrance is sometimes narrower than the rest of the ear canal. And the head and the neck of this wax was sticking out of the ear. So I often joke with patients, I can see the head, and I always often compare it with these types of cases that it's similar to giving birth. The wax is just lodged at the entrance. So here we are, we're at the entrance and the wax is just lodged there. But the idea now is to trying to bring out this wax in one large piece. If we used a Jobson horn or an ear hook, it would just slice and dice this wax into little pieces. It will take a lot longer. There we are, so it's stuck in the entrance, little wriggle, and here we go. Hey presto, got this wax out. So there's the patient's tympanic membrane. It's a bit of tympanosclerosis, a bit of scarring, so that's the white patch, and that's more anteriorly, so east as you're looking at the eardrum, and probably a bit north as well, so northeast. So medically we call that superior anterior quadrant. Just on the left ear now, so again this wax is a bit more glutinous, a bit more sticky. You can see the patient has been poking in his ear using a cotton bud. You can see the indentation just below the suction, where I am now with the suction probe. There's a little mark there at the beginning. So that's where the patient was forcing the wax in. So what I'm doing here, I'm just releasing this dead keratin and wax from the rear of the canal, ear canal, near the entrance, so the posterior canal wall, laterally near the entrance. So you often find if you release the wax, it's almost like a blind spot in both ears. So as you enter both ear canals to the rear, so to the back, so if you're doing the right ear, it'll be to the left. If you're doing the left ear, it's the back right part near the entrance. There's a little blind spot, and it's a little hidden cave, and as the wax is trying to come out, it often gets stuck in that cave. And the secret sometimes, if you release this wax from that blind spot, so if you release all the dead keratin, it loosens the plug. See, this wax is a bit more stickier, it's probably blocking my tube a bit. You can see it just hanging off the suction probe. Some dead keratin there on the, just managed to remove that. So some wax and some dead keratin. The secret again here, if I go in with an ear hook, well, there's no opening. For me to use an ear hook, I'm going to have to force the issue. I'm going to have to get in between the wax and the canal wall. The wax is quite lateral, so it wouldn't be that uncomfortable for the patient because the outer third is the medial cartilage, but this wax I already know extends very deep in the ear, so with an ear hook it will just dissect half of it. It's too soft to bring it out in one go. If the wax is a bit harder and firmer, you get the ear hook even halfway into the wax and you pull it out and it come out in a big mass. And some of the Jobson horn, what would have happened was the wax is quite spongy. You go in with the Jobson horn, as you bring the Jobson horn down, you're digging into the wax and you're almost squashing it to the base of the ear canal, or the opposite side. So if I'm going in with the Jobson horn to the left side of the wax and bringing it to the right, you're going to squash it to the right, and it'll just take longer. So here, as I'm performing the procedure, I can feel it coming, I can feel it loosening. Now you can't see that on a screen. That's what we call kinesthetic feel. When you're doing a procedure, you get this feeling, you can feel the pressure, you can feel the suction grip, you can feel little wriggles and how it's slowly moving forwards. So I know I'm getting close now, and I'm just going to, I think I'm bringing this wax, I'm going to roll it forwards and down. So I think I'm going to go to the top part in a moment. I might be wrong. And I'm going to almost roll it forward like a ball. Here we are. So I'm just bringing it down from the top. There we are. And sometimes that's how you remove wax. You always roll it out. So this piece of wax that I've got the suction probe on, it was initially at the roof. I've brought it down, rolling it forward, so it's now facing me directly. There's the big lump of wax. There's the patient's tympanic membrane, the eardrum. So again, there's a bit of tympanosclerosis, a bit of opaqueness. Someone asked me what does opaqueness means. It just means the eardrum should be slightly translucent, but that's not, it's for white patches. So we measured those two lumps of wax. It's just under a gram, so it's quite heavy lumps of wax. That was measured in millimeters, so it's just under 3 centimeters, and that's in inches, so it's 1.120 inches. I hope you enjoyed that video, guys. I'll try and upload a few more during the week. I hope you're all safe where you are.